Warm welcome, colleagues, to this public board meeting for Newcastle Trust. That's my subtle way of reminding you that we're on camera. And so welcome to those observers, both the ones we've got now and those people who will see the recording later. I'm confident that over the course of the next year our ratings will continue to increase. So think about that. I mean, if you think about the traitors, you know, there's different things you can do to maximize. Viewer, I look forward to a little bit of that during the course of this meeting. This is the beginning of a sequence of 3 meetings for board members. The first one public, then we've got charity, then we've got private board this afternoon. Can I particularly welcome Judith McKenna, who's just started this morning as Associate Non-Executive Director. She will be taking over, all being well, when Bill has to step down in the summer. At that point, she will become a full member. Judith, I hope you enjoy this, your first meeting, and you have the opportunity to meet the folk. Can I check for apologies for absence? David Weatherburn, that's right, he's in Australia now, isn't he? Any declarations of interest above and beyond the normal? Okay. With the agenda, can I check, are there going to be any surprises and any other business that I need to build in time for? No, that's good. The one tweak that we need to do to the agenda is within item 2G, when we start to focus on maternity, we're going to need to also decide whether we confirm the submission for maternity incentive scheme, or MIS. We had thought we would have time to do that at a later board meeting, but in the last 48 hours, we've brought forward an additional step required in the process. So, with your permission, we will bring in the submission lead to the meeting and Glenna, and hopefully go through that process when we Saturday. Other than that, no tweaks to the agenda, no tweaks or questions from anybody. Should we just kick on? The minutes of the last meeting held on 28th of November, normal conservative minutes, really clear. Anybody got any questions or queries arising out of that? That's great. You really got to know that. Then for the chair's report, I think that can also be taken as read. Just one thing to highlight. I think it was a very successful visit of the chair of NHS England, Penny Dash, last week. It was great that we were able to show her the new urgent treatment centre on its 3rd day of operation. It was impressive that despite all the need to be, adapted on day 3, I thought the staff put on a great demonstration of the quality of the service that we're offering there, and the improved quality that we're now in position to offer. She had a really successful visit to maternity as well, and it was great that we were able to set out the work we're doing on operating theatre and optimisation. She was really impressed by that, so that was terrific. Thanks to all that were involved in that. And yesterday we had a government minister visiting the CBC, the Community Diagnostic Centre. I wasn't able to make it because I was chair of another board, but it seemed to have gone down extremely well, and she was very positive about that. So thanks to all that were involved in that. I'm happy now to take any questions or comments on my chair's report. In which case, let's go straight on, shall we, to the bit more interesting. Rob.
Thank you, Paul. And my focus this time is really around what we've been doing to focus on the fundamentals, that first part of our strategic plan for this year. And critically, I think what we're focused on now for Q4 is trying to end this year as well as we can, to have those fundamentals in place that will enable us to build on next year. As Paul indicated, our Q2 NOF rating came out just before Christmas, and we've maintained status in the framework level 2, but we moved up from 29th to 22nd in those national tables, which is testament to all of our colleagues across the organisation and the improvements that they've been making as part of this year's improvement journey. I want to say a really big thank you to everybody around the winter delivery. it's been really busy, particularly sort of since October running into Christmas. It was a particularly busy period. There was a little bit of respite over that Christmas period to be fair, but we're now into a really busy January. And alongside that, we again, just trying to end this year as well as possible. There's a national opportunity through the elective sprint and also improvements that we can look to make in cancer access performance through Q4 with some funding available for us to be able to do that. So we're right in the throes of getting all of that geared up, established, so that we can really make sure that we end the year performing as well as we possibly can around the access to care for all of our patients. We've already mentioned the UTC. We've got a number of areas where we've now been able to open departments and new builds this year, which is down to the estates team and the work that they've done has been absolutely fantastic. But we're also right in the thick of some of the most complex changes and decants that you can have, and in particular, at the moment we've got a decant in our adult ITU here on the RBI side, and we've also got our neonates unit currently decanted for their upgrade as well. So these are really complicated things to do on a hospital site because of the nature of the high risk patients that we're supporting in those areas. But the teams have done a fantastic job in getting those decants done safely, and now Paul's team are able to move in and back on with the upgrades that are really well needed as well. So all of those things are about trying to make sure that we move on, continue to improve the quality of the care that we provide, improve that performance and access, and alongside that, clearly we're also aiming to still complete the year and within financial balance and use our resources to the best effect. So later, Jackie will come to that and she'll talk colleagues through just where we are with that, but at the moment the headlines are that we look like we'll be in a position to finish the year on with a financial balance. There's a really important paper in today's board, and this is the Wellned Review that was undertaken independently by Grant Thornton. This again is about that understanding of where are we in the improvement journey following the CQC visit in 2023. And I think colleagues hopefully will recognise, and we're publishing the full report in public. It's a really important part of our approach to being very transparent about our improvement journey. That the report demonstrates what I would expect, which is an organisation and a team, particularly the sort of senior leadership team, who have really made quite significant progress, but that there's more to do, and more to do is really helpful because they're helping us identify those areas, but actually also confirm what we knew and what we were putting in the plan for next year. So particularly around that further development around leadership and management to support our culture, some of that focus around clarity around our people and OD approach, and just that continuation of sharpening of our governance. And I think when you look at that, whilst that element of it shows as a kind of an amber red, when you really dig into that, what that is, it purely is about sharpening up all the changes we've made and making sure they're really consistent with what we do and aligning it, and this is important, to what will become our new 5-year strategy coming through. So that ability for us to make sure our governance wraps around the focus of where we're going is really important. So there's a lot of learning in there, but there's also a lot I think that we can hang on to about what we've managed to achieve, which is really positive. And for me, it's that continuation of the journey. So a bit of a theme on building those foundations, getting things in place, making sure we end this year really, really well, so that we set ourselves up for the next period. And as Paul indicated in his report, the fact that we've now got a 3-year planning cycle just allows us to look that bit further ahead and make sure that our improvement journey fits with that as well.
Very good. Good to set the tone as well so to those activities. Questions, comments, reflections?
So Rob, you alluded to the sprint money that the government have provided. Have we done a deep dive into the areas that we're going to see, where we're going to use it and see the most benefit for our patients?
So the way in which the sprint's working is that we have submitted what we believe we can deliver. It's been a very, very rapid process, and essentially kind of a headline for us it would be to try and replicate what we did in Q2, activity-wise, in Q4, which would be quite a step up from what we plan to do in Q4. That would give us the potential of an additional 8,000 patients potentially coming off from waiting lists through that activity, which would be a huge step forward to quarter. We've set a big ambition for this across the organisation, and I've been really clear nationally, we will do everything we can to get to that place, so that we can really try and make sure that we deliver as much for our patients as we possibly can. I think we as a board need to recognise we've absolutely had to do lots of cost control measures this year, and some of those have been about stopping some of the premium work activity that we were doing earlier in the year. We're reversing some of that during this period, but we've got a really clear understanding with the regional team that whatever we do cannot affect our final financial position, and that what we've got to do is make sure we support as many patients as possible within that funding framework. So we'll be focused on the areas of longest waits, as you would expect, because that's absolutely what we need to do anyway for the spring. It also makes sense for us. So longest waits will be a critical part. But also I mentioned earlier cancer, and that's going to be a big part of it.
And just thinking about that, will that affect our constitutional standards?
Yes, we're looking to see that improvement in those through quarter four.
Patrick, anything you want to add to that? How confident are we that we can do what we're saying?
I mean, as Rob said, we've had to pull this together at speed, and it works very closely with the clinical and operational team. So those plans are being firmed up as we speak, and we'll see that being pushed through February and March in terms of additional activity.
Good. Any other points to raise with Rob? It would have been nice if we had greater warning of these kind of unexpected
It would, because this is a tanker to turn around at times, as you can imagine, and we've been really clear about how we've been managing certain our approach to the year end, and this is a bit of a shift. But the teams are up for it. We've had quite a lot of positive response from colleagues who really want to get on and do as much as they can.
Yeah, better to have it than not have it, but still would be even better if it's been built into the project. Anyhow, that's another. Any more points, questions, comments as well? Thank you. Let's move into the. This is a new layout. We're still experimenting with it, where we're trying to align our key priorities to the structure of the board. I think we've probably still a little bit of work to do on it, but this section now is on the focus on the fundamentals of performance and finance. And we're starting with the patient story. We always try to get a balance between the positive ones and the negative ones, so that to keep us balanced. There's a lot of negative in here, but it's not particularly directed at ourselves. It's the system widely. Ian, do you want to bring this to life?
Yeah, before I take our staff story, I'll just focus on our patient experience story. I think it was really important that we shared this story with board. And Julian's story we actually picked up as part of our real-time programme, interviewing Julian while she was in our care. And what this really highlighted was our recognition as a large, not just district general hospital, but also a tertiary organisation and quaternary organisation in some aspects. Patients will often come into our care having had experiences in other organisations, and sometimes that experience in that organisation and in ours impacts their experience across their whole care journey. And we can see in Julian's case there were some real challenges around communication, actually with us as an organisation, but between organisations, impacting on how well she felt ownership of her own care and her own journey. What it has made us reflect on is how do we, with our work that we're doing with partners across the Alliance, but also across the wider system, understand how we can thread that patient experience and communication across organisations, as well as how we develop our processes internally around maximising the patient experience. And that was incredibly important for Gillian and her reflection through the story. But it also made me realise that patient experience programme, that real-time programme, is not just important to understand an experience of care on the ward department, but to understand the experience through the whole journey, because we may only see a bit of it on one ward, but it's much more representative of challenges across the whole patient journey and the real impact of communication and clarity of communication and somebody's lived experience. So I want to share that, and what we'd like to do with this story is look at how do we thread patient stories right at the start of the pathway work we do with organisations, and to make sure that's really clear. So we're just busy building this story and understanding how we can use this to impact some of the conversations we have across multiple lines of the partner organisations.
Very good. Let's hold on the staff story, which is really, really nice. But It really does, if we needed evidence to support them, when we were trying to make it an alliance, this is the evidence. So, Martin, to what extent do you think in a couple of years' time we might get somewhat more positive patient feedback about the communications with the trusts?
It's certainly one of our shared ambitions for the Alliance, that patients will feel more connected to one NHS model of care. At the moment, our co-action travel is very much around the full acute trust and the Alliance, and recognising that we share an awful lot of patients in common across our journey. But we've also got the challenge, as you alluded to, that this really doesn't just start in American hospitals. This is around primary care and community services, for that whole journey, and that will be another
I'm going to try and ask Dave a question, so it's not going to like this, but I think our patients think that we're really joined up communities and that the information just flows between organisations really seamlessly. But where can we see in the kind of national work and local work the ability for us to change that? Because I think people have talked about joined up records for years, but with the NHS app and various other things that people are really kind of piling into to try and develop. How do we change this? Because it is one of the biggest things I've seen in complaints.
Yeah, so one of the big shifts that they're trying to do is something called single patient records separately, and that will effectively be a central repository of information. Now it'll have to start small, I would imagine, but it will be like those of you that know the systems in the NHS, the spine, so that's a central repository of patient number followed by address followed by some really basic details. So I think the idea is that the centre starts to build on that and sort of provide something centrally that trusts and other organisations can upload into and then retrieve from. Those sort of systems are well based across the world. There are already written examples of it. I know that NHS England are currently out to find out what that looks like and how they provide it. But the real danger is that it becomes a front-end reporting tool rather than something that's actually functional and you can use as trust. So we also have the Great North Care record that's currently in place already, so that allows a great amount of sharing across the region. But again, it doesn't necessarily allow right back in the large patient record. Sometimes that information isn't visible at the bedside, which is the important bit. So a lot of work ongoing, a lot of stuff coming out nationally. I think we can continue as trust to add in the Great North Care record as much as we possibly can, and furnish it with more data that's more relevant to the individual patients. So I think that's ongoing in all the trusts across the region, and I think we're just waiting to see what the national picture is about that single patient record.
Well, and then I've been feeling.
And this story also speaks to communication with our patients as well, through particularly between organisations, and the NHS app enabling people, which is great, but the potential, and this might be more from Michael than here, the potential for patients to see results without actually having had that conversation with the clinician and therefore having to try and interpret it themselves. How are we going to get ahead of that? Because the digital change is really welcome and important, but actually our clinical team have to think differently to make that something that works for patients as well.
Yeah, important point. I've got Phil up and then Bill. Phil.
Thanks, Chair. Mine is a sort of generic question based on this patient's story, which is really quite distressing in many ways. Do we as an organisation, we can't speak for the organisations that we work with or collaborate with, but do we as an organisation follow best practice guidance on communicating bad news, and importantly, follow the NICE guidance? Reading through this, everything is done down the telephone, and my understanding is that these types of conversations should be done face to face.
Okay, who would like to respond to that on behalf? I can see you with yes.
So just two things. I just want to come back to Rob's question I was left unanswered. And just this morning I checked the clinical risk group where we were discussing how to ensure that our patients receive information about what to do next. So you've had this surgery, for example, what can we do? So we saw some examples of QR codes. Obviously there's QR codes might not be something that every patient can use, but that will enable them to access some. This is what you can do if you have a problem, if you have concern, this is who to reach out for further information. So we are trying to fill the gaps that currently exist because the systems are not aligned with what we would like to aim for. But these exist in other healthcares. Patients can access readily on in whichever way, so politically mainly so it can be done. It's not something that belongs to the sideline. Just going back to Phil, I believe that at the moment, I think that is an important question. I believe that we do not deliver bad news on the phone, but it's something that I'm very happy to take away and perhaps discuss that as our board committee.
I think it would be helpful for us to get assurance on that, and more importantly, get it right and quick.
Absolutely.
Definitely, I've got Michael just wanted to respond on this, as Sue as well on the same point. Yeah, Michael.
Yeah, I mean, I think the important thing in all of this is there is the recognition that there will be a result available on allocation, which might be distressing for the patient. Then there should be a prior agreement that that information is being shared. Now, for some patients, that is best done face to face, and we should make every effort we can to ensure that it is done that way. For some patients, actually, that may not be their preference. So the key thing is planning for that set of patient journey where results are discussed.
I think that's a really important realization.
Yeah.
Thank you. Susan?
Yeah, I think it's interesting reading the story because what it speaks to is the need for care navigation or care coordination, and I think it was really popular quite a few years ago and seems to have waned a little bit over the years, but in some cancer pathways we do have care navigators, but they often kick in at the point of diagnosis, and what this tells you is that actually it's the lead up to that diagnosis that actually is probably the key time that you need that care navigation. So it's something that we've been looking at, particularly when for tertiary pathways where they're coming across another trust into here. So it's an area that we are exploring, but it's definitely not universal across the board at the moment.
That's really helpful. Bill, then I want to
I want to say patient experience is dreadful here, but also looking at it from an organisational perspective, it's very massively inefficient for us as well. So driving meetings cancelled, unless you're phone calls, etc., etc. And a lot of issues working through the plumbing of the organisation and getting that right. So there's a win-win here if we can get that what we get to. Sue's nodding on our side. Patient experience also improve professional and we say when that's how we transform and really achieve the CRP as opposed to just focusing on reducing costs, changing how you do it.
very good. As I'm just going to slip beneath the neck, yeah?
Thanks, Chair. In reading this, obviously there's lots of things for us to learn. But what was missing, I thought, from the report is what would we do specifically next? And sort of tangible, direct actions that this trust can take so that we can address the make sure that it doesn't happen again.
Yes, that's a good point, but I don't expect it in the reports bringing the patient and staff voice. I think we quite like bringing the story quite starkly to enable us to have this discussion. And Ian, I would like to come in a second, but I think we're asking the executive around this just to have a look at where we are in the organisation. What we might take, to what extent we can provide the assurance that Phil is asking for, not on that straight binary that all bad news should automatically be delivered face to face, but it should be delivered in the format that's most appropriate for the patient. And in due course, we will be looking at further assurance about how the work across the alliance will be improving the situation. Anything more to add to that before I move on?
No, just picking up on Sam's point particularly, and you're absolutely right, I haven't just put up the work around the patient and staff storage, but there's something like providing more insurance around not just the building story, but sure about the actual provide assurance on documents specifically, and then that will come out the table as well, how we do that in store.
Good, that's really helpful. Then thank you, and as normal, I'll be sending a note to the people who are going to be on behalf of the board, thanking them for their input. But as we all know, actually bad news is our friend. It helps us to improve. But good news is our friend as well, and this is a really positive staff story. loved it. And I suspect all of us that have done walkabouts have come to recognise the value of the security officers. Ian, anything you want to highlight? Or
I think the story explains itself, and I know not just you know the security team, many of us will know Ken as well,
yeah,
our discussions and walk around. I think just a reflection of we know through our complaints data that we monitor through our quality committee, one of our biggest areas of focus is around communication. And the impact communication has directly on somebody's lived experience through our services. And I think Ken highlights through his reflections, and we can see the fundamental impact all staff have on somebody's patient experience. That's not just our direct clinical staff, but also those who support through our administrative colleagues, our security colleagues. And I think Ken's reflections really bring that to light for me, and it's incredible to see the impact some of our staff can have, and particularly some of our most vulnerable patients. So they're the key things I want to know to draw out on the story.
Very good. Don't want to downplay it, it speaks for itself, doesn't it? So, are we happy to receive? And of course, our staff membership. Good. Ian, you're still on. This exercise has been engaging us very fully for the last period, the Grants Often Well-Led Review. We've got that stage now where we have the final report and a summary of the findings and a sense of what we're doing.
Yeah, thank you, Chair. I don't want to be too much of this. I think Rob framed that well in his introduction earlier. The paper is there, and I will take that as read. It was good to see through that report, which we received earlier in January, those areas where our external reviewers found that there had been improvement since our CQC inspection and report at the start of 2024. It is reassuring to see that that action plan has led to some measurable improvements, which are acknowledged, and it was good to see that triangulated with feedback from external colleagues as well. As Rob mentioned earlier, there are a number of areas and themes which they're focused and recommendations which I know we've collectively discussed in October through our board development session at that point. They have made a number of recommendations which are outlined in the report. They are recommendations, they are not specific and measurable actions. It's important that we understand those recommendations, triangulate them with existing actions opened, which we know are work streams already in place, some examples of which are outlined in the report, and that we pull together a cohesive action plan to pull out some of those recommendations. We also noticed that recently we submitted our provider capability self-assessment as a board, and we collectively acknowledge some areas we want to focus on. So it's important that we triangulate those with the Black Launch report, so we don't end up with multiple different action plans, but a singular document, which allows us to be assured that we work towards being a very well-led organisation. A number of these workstreams relate to specific directors, and I've outlined those in the report in terms of how my recommendations and our collective recommendations around how we align those. Those directors will be working through agreeing specific actions against those recommendations in February. I've recommended a governance structure for oversight and assurance moving forward through our audit risk and assurance committee. So really that's all I want to draw out from the paper. My specific ask is to be assured that the board is comfortable to align to the work of the provider capability self-assessment, and colleagues are comfortable to agree with the governance structure to provide ongoing oversight of the actions once they are finalised.
Ian, thank you. We've worked through this at various stages, so let's not go back to basics on this. I think it's been a very positive process, and I recommend Ian for the work of putting together the things. Any comments, questions? Ian,
yeah, I think that as a board we need to acknowledge that this is a point in time, because a lot of our interviews were last August, and I think it's a good report, but things have moved on still. I think the thing to note in the report is the comment around the cultural link, and it's making sure that we have got the capacity to do that in the organisation, because through the quality committee and the improvement groups, culture comes up all the time, and I would just want assurance that Amy and her team have enough people to do the work that's going to move this forward on the case.
Amy, do you want to respond to that or Vicky?
In the new restructure, because we know at the moment that we don't have answer, the new restructure is going to help us to address all of those issues. We're hearing loud and clearly that cultural issues within the departments. We know that's what's driving the high levels of the cases and things like that. We know if we get cultural correct, then that'll in the longer term reduce the competitiveness and the more formal processes that we're dealing with. And we hope to address all of that in the redesign.
Any other comments or questions? I think we previously had assurance about the process, about the way in which one thought been engaged, and we'll also be gradually receiving assurance that the process is displayed that we've been making very significant progress since CPC's inspection. That's been now 2 years ago, is it? Yeah. Now we're seeking assurance that we've got a method for using the outcome of Grant Thornton's report to take to the next stage. It's been discussed at several levels. I feel very trusted report to me, and I think I'm seeing from most around the room that we are receiving that assurance. Are we good to move on? Thank you very much indeed. Next up, the Board Visibility Programme. Rachel.
Thank you, Chair. So colleagues will be aware that we report this at every public board, so this is our next report. And those of you who were at the November board meeting will remember that at that point in time our Stream 1 leadership walkabouts hadn't been running. We revised that programme, and I'm pleased to say that that is now back in place and well underway, as you'll see from the report, where we've outlined the Stream 1 visits. Stream 2 has continued throughout that time with our NED walkabouts, which have been really, really positive, as have the leadership walkabouts, and I've collected some of the themes and trends from the feedback that was gained from the staff who were on those days. You'll also remember that we've been making a conscious effort to visit not just our direct clinical care departments and wards, so there is a real variety in terms of areas visited over the last period. In terms of key themes and trends and real positives, in terms of staff reporting great pride in what they do, absolutely putting the patient at the centre of everything, and it is their priority. The concerns raised, and I think it's really valuable when we do these walkabouts, both Stream 1 and Stream 2, because staff are really, they feel really open, and as if they can be very open and honest with us, and any concerns that are of immediate concerns are dealt with at that point in time or escalated at the most appropriate time. Some of the concerns that have crept in this month are around estate issues that have been reported, but for the staff haven't been acted upon, but we've had assurance that that is in a plan, or we know where it is in a plan. Since systems problems, specifically around System 1 this time, and we know the complexity of that, and some instability issues which have been previously identified in previous visits, but again dealt with at that time. I think just one other thing to point out for board, on the back of the Grant Thornton report, there is a recommendation within there to measure the effectiveness of our programme. So between Kelly and I, we have met and we've constructed a survey. We will be sending out that next week to start that evaluation process and to get some information back from the boards about how they feel about our programme, which will hopefully help us to develop it further.
That's very good, although I imagine it's also the views of some of the staff more directly that might be valuable.
So we did discuss that, Chair, and because of the nature of the visit, we don't take the names, because we want them to remain anonymous and feel comfortable. There are restrictions with the survey clearly because of that, but we thought as a first step, we'll go out to the clinical boards, the senior teams, and then that will sort of, help us shape that measurement going forward.
Just a reflection, just picking up on your point, I think there are two things. I think it is right to evaluate the effectiveness of our programme as outlined in the report. A fundamentally different question to me is, do our organisation, as an executive and non-executive team, across the organisation, that is different to the effectiveness of the formal process, and I think that's a challenge for us to think about going forward, how we balance those aspects of that.
That's very fair. Yes, well.
Yeah, just as a follow-up to that, I think that's really important because the Stream 1 element, which for a period wasn't functioning, doesn't mean that execs weren't
No,
in the
absolutely.
organisation and I'm often out walking about, as are many of my colleagues. We don't capture it formally in this way because it's part of the job. It's part of what we see. So I think there's a question that is really important to satisfy sector. Some of that comes from staff survey, but there are other things that people need to test.
At some point, we're going to see the outcome of that evaluation of the effectiveness, so we can let that out. Any other comments coming through? I think on previous meetings, we regularly asked the question, and I believe we regularly receive the assurance that when issues are raised, they are responded to as best they can. So unless people have got some evidence otherwise, I think we already have that raw system-wide assurance. Any additional specific points? Thank you, that's really good. And I do value this report. I suspect we will do. Thank you very much indeed. Right, slim volume for late night reading. Patrick, integrated board report.
Thank you, Chair. Just draw colleagues' attention to the sheet after the contents page, which shows where we have had statistically significant changes from the previous month to the publication of the IDR this month. There's 4 of those in there. I just wanted to touch on one of those, which was the 12-hour ED admission to discharge standard for type 1 attendances. So this has gone from a positive trend, an improving trend from an SPC point of view to a normal variation, common cause variation. I think what that doesn't really speak to is the incredible work that the operational and clinical teams are doing in ED in terms of keeping the place safe, in terms of the extraordinary volume and pressure that we've seen over recent months. This was further extensively at Finance and Performance Committee this week, and I know it's also been discussed previously at the Quality Committee. So whilst we've seen that kind of improving nature stall in terms of the latest data, I think the counterfactual is something that we need to be aware of in terms of the improvements that have been made historically. Just wanted to pull the 2 other performance bits out of the IBR before other colleagues will want to comment. So one is around our 28-day faster diagnosis for skin. And it's just a note that this has been formally escalated through our QPR process in terms of the recovery trajectory to come through there. We always see a degradation of the skin performance over the summer months given the increased demand, but we would normally see an improvement by this point in the year, and that has been slow to come forward, so we have formally escalated that through the QPR route. And also just for the board to note that we have submitted a recovery trajectory to NHS England in terms of our 65-week weight position. Colleagues may remember there was a target from NHS England to eradicate 65-week weight by the 21st of December. We were able to hit that target and had 40 breaches at that point, but we now have a trajectory that we submitted that gets us to 0 by the end of February this year. There is some risk within there are some complex spinal cases in particular, and also an issue with some specialist testing with the ENT that introduces elements of risk, but we are working through those in terms of trying to have robust plans to get us that position.
Good, really clear. And I do appreciate the cover sheet, and I appreciate the sheet that shows where the most significant movements have taken place. This report, of course, has gone through the committees, so each of the hearing committees will have the opportunity to scrutinise their relevant bits. I will just ask, because our finance doesn't appear elsewhere on this agenda, anything further you want to highlight, Jackie, at this point? We have a chance in private board, but for public board, on the finance.
Yeah, thanks, Chair. So there is a slight disconnect on the finance report because of the timing of the report. So this is the month 8 position that's contained in there. But I can also update that at month 9 we're still on plan as Rob has pointed out. Obviously it's been a typical year financially alongside other NHS organisations, but we're working really hard to balance the position for this year whilst getting to the plan for next year as well. So other than that, Chair,
very good. Any questions, comments? Ian?
So just one additional point on that, if that's okay, Chair, just on page 69 of the report. I mentioned that board previously that there had been a concern around safeguarding training, but that was due to a data issue. I can confirm that data issue has been completed, and as of now, the actual percentages are 18 and 26 respectively, which is substantially higher than the reports. It's just to note that that was a data issue that has been rectified, and they will come from each report.
Good, that's excellent reassurance. Anything more on the performance report? Then we're into macroeconomic fears report, including regarding the safeguarding. So which of these statements?
Yeah, so thanks, Chair. We've split this report this month so that I'll take the beginning and Lydia's going to comment on the Guardian Safe Working report, which this month has some quite significant elements to it. So in the main report, you will see reference to our current position on particularly on urgent emergency care and on cancer, which has already made reference to. From an urgent emergency care perspective, we continue to face very significant demand, particularly actually over the last 48 hours, which have been especially difficult. The opening of the urgent treatment centre on the 19th of January has significantly improved the environment both for staff and patients, and any of you who visited UTC will see how it will transform the way that we are able to provide urgent emergency care for patients. It is worth noting that the opening of the UTC is the result of an enormous amount of work, particularly by the clinical board responsible for that, and we are to be commended in that. It has been a very significant exercise, and they delivered it very well. We will see the full benefits of that in the coming weeks and months. We remain under very significant pressure, however, and we will see in the report reference to a situation with an issue of particular concern to our staff of corridor care, which you will have seen highlighted in previous reports, but also recently in the press. This is a major focus for us at the moment, and will remain a major focus until we're in a position to reduce and ultimately eliminate corridor care. Important to emphasise in the discussions around that it's sometimes described as only being streamed to flow through the hospital. That's not true. Actually, there are a significant number of patients who are cared for on corridors within who ultimately are not admitted to hospital. So it's not just a matter of improving flow through the hospital. There are very significant challenges in reducing and it's largely a reflection of the very significant demand here. But there are undoubtedly things that we can do in the staff are committed to improving. You will see that despite that, the graph that's in the report of patient experience within the department, it is reassuring to see that we continue to see high levels of satisfaction with care within the department, apart from particularly around waiting, which is something which we are obviously working hard to improve for all of our patients. Patrick has already made reference to our cancer performance. This remains a significant concern to us, both in terms of compliance with the 28-day faster diagnosis target, and probably clinically more important, the 62-day target. So, reminder that the target that patients who are referred with suspected cancer should begin treatment, should they need it, 62 days, a maximum of 62 days from point of referral, which I think is a very important target in terms of care for patients, but also is well recognised as being important in cancer outcomes. Important to recognise that we've described significant challenges around compliance with that target around suspected skin cancer, but also we recognise that we also face challenges, particularly in management of upper and lower GI cancer, hepatobiliary cancer, lung and neurological cancer. And so there is a lot of focus in improving the rate at which we are able to begin treatment for patients with suspected cancer. And you'll see in the report a number of procedures that we put in place to try and improve things. and in fact, soon I have a meeting on Monday with the relevant teams to discuss this and with our regular to improve this and regular updates on action plans. We have referenced the quality and safety plans that we have, including the piece of priority project on invasive procedures. This is recognising the fact that if you look at our patient safety incidents, a significant number of those relate to invasive procedures, and so we are focusing at the moment on improving the safety of those. Luthia is going to talk about exception reporting, so I'll leave that to her just in a moment. Final thing to say is just that last element that's highlighted at the end of the report on statutory and mandatory training. We have had for some time concerns about compliance within medical and dental staff around statutory and mandatory training. That's been asked for assurance on that previously at board, and just like to provide assurance that there is currently a development of further plan within the clinical boards, which we are due to receive actually by the end of the day, for how we will reach the compliance target by the end of February.
Thank you for that last bit of assurance, although I'm sure we're also looking at what elements of statin demand are really important for blood pressure outcomes, but we have the list we've got, and thank you for that final assurance. Let's just take questions and comments on that as well before we go on to anything. Yes, Ben.
In this place, what you went on the UTC yesterday, it's fascinating. Once you talk to move through once you look at the queue of patients in the reception desk, it's structure at the front door with 2 more patients driving and standing outside. Which I know this is TV, but I don't know if we're actually monitoring what's happening at reception, where people are queuing, etc. So this is a very big queue for people inside.
Yeah, so there's a lot of improvement work going on a daily basis by the team who are staffing that, essentially looking at what are the things that they are doing that are improving that particular bit of the process, Bill, because we do understand and recognise that that's a significant challenge for people. We've not got it right yet. We recognise that we've not got it right yet, but I think that we will see significant improvement in that over the next few weeks. Important to recognise that the demand that we've seen, particularly over the last 48 hours, and yesterday was a very, very difficult day in terms of demand, has been unusual even for this time.
Hassan.
Thank you. My question is around cancer performance. So understand the issues around the numbers, skin, but you've mentioned in the report, you've spoken through the performance against the other areas of cancer. Just the question in my mind is, what does performance improvement look like? So I understand you haven't really pursued the right action, but what does the trajectory look like? Because the story of Jimmy kind of brings home a kind of real impact on patients. So I guess what I'm looking for is some assurance of what you think improvement looks like and when we might get that kind of.
Yeah, so I think that is one of our main focuses at the moment, actually, is how do we get to a position where we are, so that we are meeting the compliance targets, and that is important, but what's much more important is that are we actually getting the outcome, the best possible outcome for our patients. So each of the tumour sites have plans for that and what those look like. Perhaps the thing for us to do is to bring those plans to you for next year.
So they're going to file in for performance, aren't they? I think that would be good because, as we know, governors have got a key interest in this area. Patrick.
Yeah, I was just to say that those, how we create those plans currently and what we're going to repeat them. So, Finance and Performance Committee have taken them through the process where we've done an in-depth audit of pathways to find out where the bottlenecks are in terms of those delays. And we have action plans targeted against those. You see some of that in the medical director's report, actually, in terms of direct interventions on the back of that analysis, like some targeted investment in terms of the front end of the lung pathway, for example. So we're going to repeat that exercise to do that other in-depth case audit to refresh action plans to make sure our actions are directly targeted at where we can see the links within the pathway.
Anna?
Just following on around cancer, obviously we are a tertiary referral centre and just understanding how we're working with our partners to ensure that pathways can be shortened and have we got that assurance through the Alliance that our partners are working as quickly as possible to get patients to us to ensure.
Yeah, that was another one for you, Martin, to give an initial response. I think it's not the same. Okay.
So I think it's variable. I think that we are working and decide, agree that cancer is a key priority area for the coming year. We're working with the NCA to look at what we can do across those pathways that are always going to transition between trusts. I think things like the lung pathway, as Patrick said, we've done deep dives into that. We're trying to close the timelines between that transfer of patients. So it's work in progress. We can bring that back at a later date.
Thank you. Michael?
Yeah, I think that is important. I think it is very important that we work with partners, as you suggest, and make sure that we get referral as early as we can. However, we shouldn't fall into the trap of assuming that this is all due to late referral. So some of it is, that's undoubtedly correct, and there are things we need to try and address that. But first and foremost, we want to make sure that our processes internally are as efficient and effective as we can be.
Yeah, we can't shuffle the blame. Yeah, good. Lucia, and then I'm going on to move on to the bit with your government.
Just on what we've touched on, every pathway is a world, isn't it? And there are improvements to be made in many. It's identifying where the gaps are, to identifying improvement. We've just been contacted by GERD, by the National GERD team, so that we can share what is it that we did that led to our improvements in the radiotherapy pathway for our patients. And we've been only one of 2 centres in the country that have managed those improvements. Now that is just a tiny bit of a pathway that is going to affect only a proportion of those patients that we see there. But I think it's important that on the subject of how we share, that we are also working collaboratively and sharing what we've done in that is being into our improvements.
Excellent, that's really good to hear. Can we move on now to the other part of the medical relations report? And just to say, after this, I'm going to take the 10-point resident doctor plan early, because Sam, you've been able to join us, but don't want to keep you here more than you need to, because we'll complete the medical relations report first.
So just to touch on the jargon of safe work report, which is attached to the papers, and I'm going to take my break. In it, I'd like to draw attention to the exception reporting that we've had this for the last quarter. We've got just under 1,200 resident doctors. We have had a total of 126 exception reports in this period, which is lower than what we've had before. There are some significant changes to exception reporting that come to the fore next week. They are detailed in the report itself. They are significant changes because those exception reports, which basically are when resident doctors have to stay beyond their hours because of whatever reason. So those exception reports will be reported directly to HR, medical staffing, and they will be with oversight from the Guardian of Safe Working. That means that they will bypass, as it were, the educational supervisor, which has pros and indeed cons, because there are some concerns about how is it that we would identify and be able to support those residents that are persistently having to stay longer. How can we? So there is a lot of work that is at the moment underway to try to address those concerns. We anticipate that there's going to be a financial impact, which is impossible to calculate or estimate at the moment, but we'll bring that further to this to the board and committee in due course.
Thank you. It's frustrating that we won't be able to continue to have comparative data as a consequence because of this change in reporting process, but it's nice to see that the moment the exceptions are Liz.
Great detail here. You say that the greatest concern is this reporting system and the 4th of February is looming large.
Speak up a bit, Liz, please.
Sorry, 4th of February is looming large. So I just wondered what risks were around that system's readiness, what you're doing about it, what support you need.
So there's a digital system through which doctors will have to issue the reports themselves. This is a national problem. Everybody's got the same problem at the moment in that the system is not ready by the time we need it to be ready. We're going to use trust. So we will trust our residents to be honest and truthful on their reporting, and then we will do some assurance of audits along the way. This is very much the approach. Others, other trusts, actually within the region that took these measures, they brought them early into the trust. They did try other things like can you geolocate yourself when you were at that time. We're going to go on trust.
Okay, thank you. Thank you.
Good. Any final comments on the subject? Yes, Rob.
I just have one, which is, so medical staffing is the area that's workforce has grown the most in the last 5 years. We're using exception reporting to identify where we've got issues. Are we analysing areas where we don't have exception reporting either because to understand why not, and therefore considering whether or not we've actually deployed our medical workforce in the right way to manage the workload across the organisation? Because the report goes into we may need more, but actually the question is, actually have we got potentially people in the wrong place?
Yeah, so that is very much one of the questions that we are currently discussing. Now, because we don't, so I guess that through these changes, that might open the door for further intelligence into, I see why, and I see what's happening. But also to share those areas where there will not be any changes to those exception reports. And actually, they are working very well, because we've got it right. So I think that the next couple of, over the next year, I think it'll be really interesting to analyse that data and understand what is there.
I think we've been really worth some learning from the much more established nursing service staffing approach, which has been in place a lot longer, and we can see a map and understand actually where you're balancing risk and how you're managing that. I think we see one lens currently from a medical workforce perspective, whereas in the nursing is much more comprehensive, and we can actually understand where our risks are, but also where our opportunities are as well to support.
That's a really interesting challenge that Rob set for. Let's not try and dig into it too much, but I can imagine people in culture enjoy having a bit of a dig into that.
I think it's accepted that 126 reports for almost 1,200 residents is under what we would accept to be a good number of reports. So I think that the changes will lead us to a better understanding of what's happening.
Understood, yeah. Jackie?
Yeah, I suppose just picking up the point about taking on trust, and I completely understand that. You know, I think probably something for the Finance and Performance Committee is the assurance around controls that we've got around that trend analysis and address. That's something myself and Jim.
Good. Let's ask the executive to take that away and chew over the best ways of taking forward. Thank you. Then, as we come to the end of the report from the medical directors, just remind ourselves of the challenges in urgent emergency care at the moment. It's a bit scary that obviously coming in at the moment, and not just here, it's worth saying. Congratulations to all involved in the opening of the ETC, noting that there's further to go, particularly to reduce the queues, which I feel uncomfortable as well. There's plenty more work to be done on cancer. I think we've got assurance that the work's taking place and that the focus is taking place. And congratulations to the improving performance in most areas, but there's more to do, and we need to keep very much on that. We have received assurance relating to staff and management training, for which thanks, and we've heard about how regarding the safe working structure was going to fairly fundamentally change. But meanwhile, just to promote the exception. Thank you very much indeed to all for that discussion. So now, with your permission, I'm going to lead on to look at the resident doctor's 10-point plan update, which is under 3B, because Sam, you've been able to join us. This is a really important piece of work. How do you feel it's going, Sam? You can assume we've read the report.
Thank you. I feel like it's going very well, actually. We have met fairly regularly as part of the steering group with lots of faces that are here already, and I'm finding that there's a lot of positive energy into highlighting issues that is out with the 10-point plan as well. So I feel like as a trust we are not only just meeting the bare minimum of what the 10-point plan sets out for that national intent, we're actually probably ahead of the curve and delivering, or on track to deliver more change than they would expect. There are some issues in regards sharing the lead employer trust model with the vast majority of our resident doctors being trainees employed by the lead employer trust. So there are some things that I would love to have a bit more speed and development on that are out with our control, because we are waiting on either national or regional approaches to be forwarded to us. But from what we can what we can see and what we can achieve, I think there's been a lot of visible changes happening already, and lots of plans in place with actions laid out going forward. Effectively, so far, we have primarily been focusing on facilities, seeing how our facilities impact the working lives of our resident doctors, to try and maximise what we can on when people join the trust, whether that be with handbook and information, and also in regards to how that first 30 minutes of our working day is. So from parking through to change facilities, through to bike lockers, physical locker space on wards, the whole host. It's a bit of a timeline that we're looking at to micromanage each individual part of that. There are obviously some larger elements which will take longer, such as IT provision, specifically finding areas within the trust that are not functioning well for our resident doctors, and kind of scrubs policy and other things that go into just the day-to-day bit of our lives. But generally, globally, as the resident doctor peer lead, I'm seeing a lot of positive engagement. It's interesting though that the resident doctors at the coalface aren't yet fully engaged in the process. I feel this is an NHS England derived 10-point plan, and so until they actually physically see lots more changes, I think they'll still not be fully on board. But I think a lot of that's going to be around communications and to show them what we've done.
And that was going to be my question to you, because you're closely enough involved so you can see evidence of progress, and I'd like to hear it. What can we do to ensure that resident doctors throughout the patch are understanding what we're doing, and that they're feeling their voices being heard in the development of the plan?
As part of the discussions at our weekly steering group, I think we recognise that we want to deliver, you said we did, kind of approach. And so we did run a full facility survey out to our resident doctors at the end of November, which garnered an awful lot of information, more than we were expecting. And there are some quick wins certainly there, and that'll be clear to us when we deliver some communications, I think, to the team. But I would like to put a whole package together to say, I'd like to give it time so that we can make some larger changes to then deliver that communications package in due course.
Caroline, anything further on that point?
Yeah, I mean, I think we've had some really helpful conversations through that steering group, and that is meeting regularly and have had really good support from all sorts of teams across the organisation. And it's not it's a programme of work rather than a one-hit kind of approach. We've got junior doctor induction on Wednesday next week, so that's our first opportunity really to start fresh with a group of new trainees coming into the organisation and get that right. I think what I've been really struck by, as I've been talking to resident doctors, both within that group and around the organisation, is just the difference human connection can make for them when they are rotating and they're coming into the organisation. Having someone who welcomes them, who contacts them beforehand, who will show them where to put their papers and their baggage to make them feel part of the team, is something which we get incredibly right in some parts of the organisation, but it's variable. And I think there are some things that we could improve quite dramatically, quite quickly, if we can get that approach right. So it's really welcome to improvement.
Thank you, Anna.
Sam, are we learning from the trusts as well, where they're doing things better than us, and getting that information across the alliance?
Yes, I would say. So I know Paul have been in contact with Northumbria from a facilities and technology component to that. I think we are at the early phases of this, and it's been rolled out nationally, so I think all trusts are struggling to get to terms with what this actually means to, on the ground and what changes there might need to be developed. I don't think this is going away anytime soon. This is going to be a continuing stream, and it's nationally, there's national markers towards it, so I think it'll be ongoing. Myself and other peer leads, because every trust has a peer lead, are in communications about particular issues that we're trying to overcome. I think each trust has their own individual potential pinch points, and certainly a trust this size stands out in the region, in James Cook potentially. So the issues that we face here are actually seem a little bit different to other places. But yes, there are lines of communication. I think the LET and Education North East are the main pivot within this.
Yeah.
Just a brief reflection, it's really important work, and it absolutely requires a focus on some of the unique challenges our resident doctors face. I think we should challenge ourselves with what learning will you get from this, because a lot of these are basic workforce hygiene factors which impact on the whole organisation and not just the resident or professional groups. So I'm certainly interested, as this work goes on, to understand and evaluate the impact on staff experience, so we can make sure we embed that learning into the wider professional groups.
Very good. Have just gone through quickly.
Certainly the 10-point plan, when it first came from NHSE, came into people and we've had updates through the theatre committee. So that's, so it's, well, I think it makes a great point. It's such a basic hygiene practice and actually, being into the scrub rooms and getting changed and experienced the kind of close proximity and kind of lack of facilities. It was kind of a bit of an eye-opener when I went and experienced it and did it with some of our clinical staff. So that was, we kind of hear these things and understand them, but actually when we go and do it, you go and meet these clinical colleagues in the meeting when they're in between sort of data lists and trying to find, actually, when you feel it and see it, it's not acceptable. So we should lose sight of it. Like many things, we're dealing with a legacy of an estate that's not fit for purpose in all these cases, and that can't just be open for the switching group, but we can't. So these things are in capital programs, we need to create space, we need to create more mess facility, we need to create a better look at space, changing space, shower space, all of which are coming through. So it's kind of, you look at the list and you think, well, it's one of them that apply stuff, and they just box on and crack it off. Payroll, errors in kind of role management, it's kind of, but if it was that easy, it would be fixed. And so it's not. So we've got to be on it because it's not acceptable. We're on a journey, so I think it's not people say progressive. But I think part of the messaging is people knowing there's a journey and where we're at the journey and what's coming when on the journey. And I think, so at least we can win the hearts and minds to say, it's not right, not going to be right for some time, but at least we know we're heard and people are on it. I think this is a crucial thing. But I think equally, these issues are probably prevalent for many of the groups of staff.
Yeah, so underlining the importance of the work, and thank you for Sam and colleagues for your engagement in it. Recognising we are making progress, but we've got quite a bit further to go. We've got further to go in communications around it to ensure that resident doctors are engaged. It's a challenge because they're coming out when they come. It's a new lot that we're seeing next week, but we need to find continually improve our mechanism for that and the support about learning from this. It's not just resident doctors, somebody who's a wider
Just wanted to commend Sam actually.
Yeah.
He's really thrown himself into this. We've got a great collaborative style, but actually underneath it challenging us appropriately. So when he said earlier we're just looking at other things than the 10-point plan, actually Sam sat down with Ethereum and went, that's great, but there is this. And I think that was really important that he feels able to do that. So it's great for him to come to the board to describe what Sam's right at the heart of that, and I'm sure the board back him to challenge us to continue to try and develop.
And a bit like Sam, you will take away the willingness, the commitment of the board to this area of work, allowing us to challenge ourselves on what we continue to do. Thank you very much indeed for coming. Can we go straight back now, back into where we were on the agenda, and Ian, you're back on, you're busy today.
Thank you, Chair, and I should be brief, just to make sure we've got a bit of time for the maternity section. So my report is there, and I will take it as read. There were only 2 points I want to draw to the board's attention in the safe staffing section. Just to note that I continue to focus on a particular concern around enhanced care observation and including plenty of our patients. There are local mitigations in place, and there is tight oversight that continues to provide challenge across our water department, and particularly more recently in our emergency department, due to the patients that have come through our department. So, noted the risk that we have to oversight are appropriate to bring to our board's attention. And my final point relates to our vaccination section. I did note in my report that there was some further data cleansing that needed to happen around the vaccination. That happened this week, and our current compliance, not like the monitoring it in an inch of its life, is currently at 64%, which is a substantial increase. So as of yesterday's figures nationally, that makes us 14th nationally with our data claims, and actually takes us to 4th nationally in the 3rd region. So that's actually testament to the hard work of the teams who've really focused their attention on this. And we will see our final national position at the end of February at the next data comes through.
That's absolutely terrific on the vaccination. Congratulations. I know how challenging it's been, but great work done. Given that we need to go and spend some time in maternity, are there any questions to any other parts of Ian's report? Then we're happy to note it, note the oversight report in safe staffing, and note with pleasure. Good. Just to say to the other colleagues, we've had to shuffle the agenda a bit, so we'll still be refusing this, I'm afraid. I hope you can just enjoy as a spectators, because we're going into maternity.
I think I'll introduce General to take us briefly through our normal report, and then we'll just do a small focus on the MRS compliance piece. So I'll hand over to Jenna first.
Jenna, over to you.
Good morning, everyone. I'm really pleased to bring a relatively positive update from maternity services, and you'll see from the paper that there are some positivities from the CQC maternity survey. We had really good response rates from a variety of our service users, which saw an increased performance across both postnatal services and antenatal services, with a real positivity around the triage. So some good news from the CQC maternity survey response from our service users. And I'm pleased to update that the data quality issues that we've been briefing the board with on a regular basis have been resolved by the North Eastern Yorkshire Analytics team. So we have received an updated Q3 dashboard which has removed the duplications, and we are now back within the centres in terms of preterm birth, APGAR scores and stillbirth. So some progress from a data perspective, but I didn't want to take the time this morning to focus on the maternity incentive scheme. We're approaching the end of year 7 of the scheme, and I'm bringing to you a proposal to confirm compliance with all 10 safety actions. So I have got a very brief presentation in accordance with the technical specification to talk us through, and I'm expected to be joined by Marie Smith, who's our head of obstetrics, as required to challenge the 10 safety actions. So as you'll see from the presentation, the Trust would like to confirm compliance with safety action 1. The board have received the quarterly perinatal mortality review tool reports, which outline compliance with the standards. In addition, this will be externally verified by Embrace. The safety action 2, which is our MSDS data, we've already received confirmation from NHS Digital that we are compliant with the standards required. The safety action 3, which is around our transitional care provision, we do have an embedded transitional care service, and we have provided the required quality improvement project updates to both the safety champions and the LMS, who yesterday verified compliance with this standard. Safety Action 4 is around our broader workforce metrics. We're compliant with the elements from an obstetric and anaesthetic perspective, and in regards to the neonatal staffing, from a neonatal nursing perspective, the only outstanding element is around the qualified in speciality, and we're required to ensure we have an action plan to achieve that. As you know, we have escalated through both this board, the LMS and ODN, the lack of a QIS training programme within the North East and Yorkshire, and that is within our internal risk register. As this is the only outstanding action, the Trust is compliant as it is continuing to work towards the action plan with the ODN to ensure QIS training is available to our nurse staffing. In regard to Safety Action 5, which is around maternity staffing, the only outstanding element is the sign-off by yourselves of the action plan, which is included within the paper. We have received confirmation of the funding to ensure that the Trust is compliant with the Birth Rate Plus, and there is a comprehensive action plan to ensure we recruit the appropriate staff to fulfil those requirements. So pending confirmation on the action plan, the Trust will be compliant with Safety Action 5. Safety Action 6 is around Saving Baby Lives Care Bundle. The ICB have an improvement tool which we have been using and submitting on a quarterly basis. And again, the ICB confirmed yesterday that the Trust is compliant with all elements, including the very difficult standards around smoking cessation and the audits that are required to underpin that. In regard to Safety Action 7, we've previously escalated our concern around a lack of appropriately commissioned service from the ICB, and the Trust has fulfilled its requirements in terms of escalation via the perinatal quality surveillance model to both regional and national teams in terms of compliance with standard. Safety Action 8, probably the most difficult, around training compliance across our multidisciplinary teams, has been achieved, and we only have a small number of trainees who still require training, and that will be completed by the end of January. In terms of Safety Action 9, we have good relationships with our safety champion, we meet regularly, and we have demonstrated that we share the required safety information to both the ICB and yourselves in receipt of the MNSI reports and PSI papers as part of the board. In regard to Safety Action 10, there is an additional supporting evidence within the reading room, which has been verified by Ian as in his role as Executive Director of Nursing to demonstrate that all families have received the appropriate information in regard to the MNSI and early notification scheme, and we are continuing to share the quarterly reports with yourselves for information. So in terms of the service position, we have got the required information and would like to request support of the board to confirm compliance with the 10 safety actions of Year 7.
I think it's worth noting that certainly the last 2 years that I've had involvement, we have not been able to provide that assurance. So this is really significant progress that has been made. Ian, we need input from Marie, do we not?
Yes, we do. I've just been informed we've been trying to dial Marie in a couple of times just into the meeting, and she is having some remote Wi-Fi issues, which is made it difficult to be able to do that. What I'm proposing, if the board are sure that we'll pick up a secondary conversation to make sure that we've got appropriate check and challenge for Marie to be able to do that, and that would be appropriate for us to then be able to provide.
So I'll take questions and comments first, but then we might be needing to approve subject to the confirmation from Marie and the but let's take Anna first of all.
Yeah, so I would just like to give the board assurance we've been tracking these 10 actions through the Quality Committee for the past year, and I'm really assured that we are compliant. I think Jenna has moved the mountains, especially on the training element, and we can't underestimate the work that's gone into achieving that specific element, and the team should really be congratulated on achieving the 10-point plan.
Very good, very good. Thank you. Do you want to see you, Bill? Was you up? No, okay. Any other comments from the board? I think we are ready to approve, subject to confirmation that the appropriate challenge is coming from Marie. You'll get the wording right for that, but this is a somewhat legalistic process which we have to do. As I explained at the beginning, we were expecting to do it next month until yesterday when the ICB changed the timetable goalposts when we were expecting. Okay? Then that's any other. I'm about to take us on to the Maternity Champions report. Just before that, any other questions or comments to Jenna? Then Liz, your report for Thank you.
Thank you. So I'll take it that the report's been read. My general observations are, and I think the fact that we've just had this presentation from Jenna speaks to this, that there's a really strong culture of patients first and patient safety in the department, and I think Jenna gives us an excellent example of leadership in action and making a difference and making an impact. I have certainly seen high levels of patient satisfaction with the patients that I've met and their families, and I've also found that staff are very open to having conversations and being truthful and transparent about how they feel about being in the department through this time of change. There are some issues, mistakes issues, which have already been referenced in the visibility report, primarily to do with the building, fabric of the building and the location. Everything's been escalated to the appropriate department. I'm confident that they will be acted on. Also systems issues, well, we've heard about that as well. These are constant challenges in large organisations. But I think the really good news is to see and to hear just now the progress that's been made in the department, to have assurance from me that the culture and the staff experience and most importantly the patient experience seems to be extremely positive and improving.
Thank you very much indeed for that. Paul, do you want to respond at all on the estates? There's actually loads happening, isn't there? But as ever, loads happening, loads still to do.
Yes, thanks, Chair. I think, first of all, what's been great is Liz, Jenna and the team have been pretty restless about the fact that it isn't good enough for women and babies, and that's not been from trust leadership for a while. I think that what I'm pleased to be able to do is the board will remember I came with the capital plan beginning of this year where the clinical priorities were around emergency planning, the cardiology and support to our maternity department, our midwives and the wider team. In the period 22 to 28 we'll end up spending about £10 million on the estate. The maternity assessment unit was completed about £500 million. Right now this year, having referred to Halcyon Street with support from one of our construction partners who were passionate about that particular issue. The big thing that Jenna and the team have managed to deliver for us is a TCAM that allows us to get a special care unit project underway. So we're spending just over £3 million this year and next to remodel and reshape that as best we can. And then in 27-28, the board will see this as the 5-year capital plan comes forward in the next couple of months. We'll put another £2 million worth of work into the delivery suite. More importantly, on a day-to-day basis, for us in particular, there were about 18 minor works but important things that were escalated to the clinical board that they prioritised. 10 of those get picked up in the big work we're doing now, and then the other 8 are being handled now and done for the team. So it isn't good enough. We're investing in it quite heavily. It is the priority for everything we're doing. And it's been brilliant that people work with leadership to get it going because it's not been easy for the team to be at Christmas. And having me head in Jenna's ceilings and floors last week and just realized how complex that's been, it's a cracking bit of work to support the amazing work that Jenna's been doing in the department. And thanks to Liz to just keep going on that stuff.
That's great, and thanks to the staff in general, because we're having to work round as we do some of that.
Yeah, it's
new development.
awesome.
They're trying to be very flexible on that. Yeah.
Just very briefly, just another key aspect, in particularly of your report, is particularly on that gynecology pathway in the organisation. I know that's an escalation that we've also discussed with our quality committee. I can confirm with the board that we've agreed a plan for that in terms of the transformation of that area, which the teams are now working on to commence and start making.
Oh, that's really reassuring.
That's great. This is an area of work which we're making fairly rapid progress and improvement on. And part of that is because we remain open to challenge and to the next steps and the next levels of improvement. So I think all of that is also for the challenge that's been coming through this campaign report. Jenna, I'm sorry, I didn't see your hand up. Jenna.
Thanks, and it was just to reflect on Paul's comments. So whilst the disruption in terms of the decamp was really impactful for the staff, in the current context of the national scrutiny of maternity services, the staff have taken the investment by the Trust Board and both the staff and the state incredibly positively. And despite the challenges of the decamp, everybody has been incredibly positive and fully appreciates a no pain, no gain situation. So it was just to reflect back from the staff that your investment in their service provision is hugely appreciated.
Good. Well, I know you'll underline to the staff the commitment of the board to seeing this through and seeing the next stage of improvement through as well. Thank you very much indeed all. Let's move straight on. Developing the service review programme. Sue, you've been unaware of this.
Yes, the board will note that you've seen this document through private board, and we've also scrutinised it at F&P previously, but just to bring everybody up to speed with where we've got to, we obviously made a commitment as a trust that we wanted a formal comprehensive service review programme in place to support us going forward into next year to develop high quality and sustainable services. So there's a really structured approach now that we've set up where all service areas go through a tier of the service review programme, and those services where we have concerns about future sustainability, clinical model, fragility, we will put them through a more detailed service review programme. So the slides give an overview of how we construct that service review and the lenses with which we're looking through that. So the team have been doing a lot of work around the data collection to be able to provide the intelligence to start to form a case for change in some of the service areas. We are coming back to board in February with 2 service reviews, one in cardiothoracic services, which has been going on for the last 4 or 5 months now, and one in HPV services, which also has been going on since it was escalated through the QPR process. We're also moving on to cover some work in ophthalmology. So we've been talking about ophthalmology from a quality perspective for some time, and we've undertaken a formal service review in that area. So it's just a heads up really to the board to be prepared, but they're coming back in February in a more detailed format.
Very good. We've been following this process and encouraging it. Have you just taken back any comments or questions there? We'll have the more substantive debates next time if we start to look at the outcomes from the first interview. Thank you very much indeed, Sue. Good. Now we're into the next section, making it better for colleagues. And we've got one item of this we've already covered, but really important items was the back around the anti-racism framework. And we're joined by Leanne and Elijah. So thank you very much indeed. I'm feeling a bit embarrassed that you're sitting off the main table.
I'm going to see if we can...
Can we do a little shuffle?
Can we shuffle in a little bit?
Yeah. So that's people up here. Thank you. That's kind of you, Alan and Martin. Appreciate it. Good. So, over to you.
Thank you. Can I just take a moment to do a quick introduction for Alicia, who's our patient experience manager for Quality and Diversity, and Leanne, who's part of our staff and patient experience team, who's also the chair of our Race Equality Network. And it's a real pleasure to introduce this piece of work, which I hope everybody in the room will feel that they've been connected to in some way and have some real support from the board around the whole of our EDI approach, but particularly our anti-racism work. And I know that everybody's been involved in workshops around that. We've also taken it as a people committee and business management group. So it feels like to me here today is the culmination of a huge piece of work which has absolutely been led by a small fast group of people which Alicia and Leanne have been a part of. Other colleagues as well from our global majority who have really been passionate and working on this for probably over 2 years. It's really fair to say that when I first started to get involved a shorter time ago, there was quite a lot of frustration about the slowness of the pace of change and the lack of engagement, the lack of connection with the wider organisation. I hope that we've turned that around now, and I can see that real commitment from our leaders around this table, our operational leaders and leaders in the organisation has come to the fore. I thought it was really important to invite them to come and speak to us today just for a few minutes about our anti-racism framework, which is in the pack and I'm sure people will have the chance to read, and then we'll just summarise after that by looking at what we're going to do in the commission. So I'll hand over to Leanne.
So the first slide really talks about what does anti-racism really mean for us as an organisation, and I've presented this obviously to the people, committee, etc. But today I just wanted to just slightly change the way I talk about it with yourselves and just really bring more of a human element to it. So for me, what it really means in practice in the organisation is, I guess from a personal perspective, when I walk into professional spaces, even healthcare spaces, I quietly have a question within me that I have and I ask myself, and it's really, will I be treated fairly? Will assumptions influence decisions that are made about my care, my credibility, and outcomes? And just really, will there be a space, if I was a patient in an organisation, would I have to think about the clinical curiosity that is applied to a white presenting patient next to me as a person of colour? And those are kind of questions that really in practice help us think about why anti-racism and anti-racism framework is important. We'll go on to the second slide. And just really where it might show up in our hospital systems, we all know that, you know, from a historical point of view, even including the way that the colonial system of care from a medical point of view was established, is that it was presented in a way that, I guess, it looked at people, the knowledge, and kind of all the background clinical way that things were presented is based upon the systems that it was built on now. And still those inequalities are still present in our systems, unfortunately, today. We see that in care pathways, we see that in the workforce practice, and in decisions that have been made where people don't look at it from the lens of that equality that is needed. So the framework is important because it addresses exactly what we've just spoken about, based on the driving, the four driving guiding drivers that we have there, which is education, representation, culture change, and action and accountability. And really from a board's point of view, what that does is it moves from your commitment, which you have, into assurance as an organisation. And really important that we can look at making sure that everything is smooth, because when we look at the organisation, we want people to walk into this organisation, whether you're a patient or a member of staff, to be able to walk in and know that you're treated fairly in everything.
So just to touch a little bit on more what I said about the impact on patients. So I'm sure I'm telling people what they already know in the room in terms of understanding in our local region what inequalities that exist depending on your ethnicity. And the way that's pervasive in ways that you can sometimes identify and sometimes not. I think a lot of the time when we talk about the training, we focus on the interpersonal aspects of racism, whether they're intended or not, towards patients. And as Leanne touched upon, it's the sort of the comments that you get when you go to the reception desk, presuming whether you do or don't speak English, or making assumptions about your cultural background before you've had a chance to actually give your own opinion. And a lot of research has shown that if you're a person of colour, you have less trust in the healthcare system because of these experiences. But due to deprivation, if you're a person of colour, you're likely to live in areas of deprivation for certain conditions, you're more likely to have them. So you're more likely to need them care and then have a poor experience when you're going. And we get spoken a lot in relation to EDI that when we get it right for a marginalised group of people, we get it right for everyone. And I think sometimes the lens, which is great to see it being widened, we focus on a certain group of people, but actually the benefit that this can have for our staff, which are also our patients and patients which are our staff, and all patients accessing our care, I think it can't be underestimated the benefit that can have. And to say it's a lot of work that we have to do because so much, as Leanne again touched upon, of racism colleagues in healthcare in terms of the people that we have who are attending research, the different conditions that get funding, even down to the training which we have, but now our pressure officer training we focus on pressure officers on darker skin, but that would always been that way. So there's quite a bit to do, but as I say, moving people to action is really, really welcome from the staff and patients alike. And I just touched upon there about the feedback that we've got in relation to racism, which is obviously a very small amount of complaints in PALS. And I mentioned I was speaking with that racism, whether intended or otherwise, is the impact of making someone feel less safe and less welcome in space, and that impacts on your ability to provide feedback or complain, because if your care is already impacted before you say anything, obviously you're concerned with the success of the you or a family member. So the amount that we've got through is almost just the tip of the iceberg of what's actually happening in our hospitals. So I think, yeah, we need to understand that further, but even without the data there, it's about saying we know it doesn't actually reflect what's going on.
Thank you both. I'm always very affected by the testimony that our colleagues give us, because this is not an issue which sits inside this room or outside of any of us. It is something which is absolutely here at the room in our working. Once we've approved, hopefully, this framework today, there is a huge amount of work to do to start to make the changes that we need to see. We need to know that some of that has already changed. We are about to commence an awareness campaign to ask staff in particular to report racism, because we know that that is not done well. That is very much a campaign that's been supported and developed in partnership with the Reciprocity Network and the Anti-Racism Steering Group. And then we've also refreshed our EDI approach more generally across the organisation, so we now have each clinical board representing nominating somebody to represent them on the EDI steering group, which is where we will take all of this work forward. We've already seen some fantastic developments in the maternity team, where they're running their own anti-racism work, very much linked to education and self-experience. So that's a real trailblazer that we can learn from. We all have actions around EDI, and I would really encourage people to think about that and think about how we can incorporate anti-racist practice into that. I think we just keep reminding that we need to keep coming back and reminding ourselves this is both about patient experience and about staff experience, and in many cases they are the same people who are new to work here as well as decisions. So this is very important.
Thank you very much indeed.
Thank you, Chair. Thank you both very much.
Great.
And I guess just to say that with my colleagues, this is very real. I got a working confidence complaint, concern about racist behaviour in one of our directorates just yesterday. So this is absolutely very real, and I don't want anybody to be convincing themselves of anything different.
Just to reflect again, thank you. And I think what I'm particularly pleased to see, and will be very happy to endorse, is that we're taking a collective and collegiate approach to this, because it impacts both patient and staff experience. This is not a staff experience that will fundamentally impact quality, safety and outcomes for our patients, and our collective ownership of both aspects of that in this strategic approach, I think is both important and challenging for us, and something to see.
I'm assuming, Bernie, that the people committee is going to modify.
Absolutely. As you mentioned, speed on at least twice was, but there's always one issue, wasn't we tried. It would be hugely important piece of work. Quite dedicated and sort of passionate people. And so we've been offering support on that.
Thank you.
To the colleagues.
Good. Wendy.
So it's a great piece of work. Thank you for coming here today. Because I'm sitting here always sort of reflecting on what do I need to do about my own behaviours and to change those or change the way I think. I was really interested in the comments on the colonial way of how interest was established, etc. So thank you for all of that. And I suppose my specific point really is how Patrick and Rachel just think this through about how the work around that anti-racist framework now in essential delivery of our health inequality strategy, which we've also agreed as an organisation. We've got each of the clinical boards now who are identifying areas where we think we've got quality variation, health inequalities. Now, I'm not saying this isn't happening, I just think we just need to really make sure that we've got the focus through those discussions and that looks at ADI and not just at because there is a fear into deprivation as well. So it's just I suppose to think about how we take that work forward as we develop the plans around health inequalities and link to the broader trust strategy.
Powerful point. Sue, I'm conscious of time, you can just well.
I think what I was going to say is it's great to see that there's some good work going on in maternity. There's something about a blueprint of good practice that we can share, and we're doing services up where they're doing it really well with those who are at the beginning of the journey. So,
that's great. Robert, then I'm
Yeah, so just really simple. This is an area that I'm so pleased that we've built to this place. Right from the start of, I guess, 22 and after, it is still real, but it was so clear that we have a challenge, we have a significant problem in the organisation that whilst we've sought to make progress on various cultural things, this is really, really important that we actually set out a very clear position. And I think we've attempted to be clear in the past, but this is much clearer. There's a real framework to it. It's not just some words, it's actually putting something into action. Colleagues will know that when I did a message last year around some of the challenges out into the organisation, I was really, really clear I was not going to do another one until I had some tangible evidence we were doing things rather than just saying things. So I think this gives us that platform, and it gives us the ability to do that. I'm really committed to it.
That's right.
I just want to say thank you to Caroline and colleagues and Leanne and you support for bringing this and all the work that's gone into this. Personally, I know how important it is, and we've been on the end of racism recently, in fact. So, hugely important. The message to the board and board colleagues really this. We knew the intent which we have, we did the framework which we now have, but it needs support and investment because without that, we're falling. So, if we can, if we have proposals to support our way to this, look at those to support those.
Good. I think that there's no question we're going to be approving the framework. I have no comments suggesting otherwise. So, underline the thanks to those colleagues who supported it. We've already had some discussion about what will it mean next, and Sue and Patrick are going to give some reflection around some of that. That sounds giving us a kick to make sure that we don't get it done. Obviously, Rob has underlined for it to be a real commitment, it needs to be translated into action. We know we've got some evidence of actions improving, but we're not going to sit on our guns now and just let it roll out. This has got to be driven with energy. But I think from the colleagues that have come here, I think we can detect the energy, the commitment, and the understanding. So thank you. Well done. Colleagues, you'll be conscious of time now. We're into the last lap, so the other items are going to be largely for assurance and the full guide section. We're into that, I should say, with no question, I'm not going to finish that well. Board assurance.
Thank you, Chair. This paper has also been through ARAC and also there's been discussions through all of the Tier 1 committees this month as well. We've seen quite a lot of updates related to the risks owned by Quality Committee, Digital and Data and People Committee. Those changes are summarised on the front sheet for people to look at. I was just going to mention two things in particular. One is that the risk score in relation to risk 6.1, which is owned by FNP and is the failure to manage our finance effectively. We've actually seen that risk score reduce from 20 to 15, which I think speaks to the financial discipline point that was made earlier in the meeting. I think it's testament to all the hard work by the operational clinical team supported by Jackie's team to get us to this point. It's really been a very difficult challenge to get to that point. And then lastly, just for board to consider risk 7.1, which is owned by Trust Board as a risk. So that's the inability to sufficiently influence priorities or key partnerships. The risk scores have remained unchanged, and the action progress indicators and assurance ratings also remain the same. But 4 new actions have been added, to that in terms of refreshing the Alliance strategic intent, establishment of a clinical framework group across the Alliance, review and simplify the governance across the Alliance, and also approval of the Alliance construction programme in there as well. So I don't know if Martin wants to speak to any of those specifically, but just to make sure that board were assured on that respect.
Thank you, Martin.
Thank you, Chair. Just to point out that the Alliance committees are Tier 1 committees of this board, the Assembly Finance Committee. That in the reading room we continue to provide the minutes for all of those meetings, but this month we've also got the strategic risk registers that support that board during this period. It is with pride that there's 10 risks that we've got. That is the joint lowest rate of risk that we've got. I think we are making progress. And what colleagues will see is that in March we'll be bringing back a paper about that strategic intent for the Alliance of further discussion.
Very good. I had contact with David Webber as Chair of Audit, who recommends the approval of the MAF. Comments from committee chairs, in particular about the summaries, content with adequate endpoints. I'm seeing nods and shakes in the appropriate way. Are we ready to approve the MAF? Thank you very much indeed. Then we're into the committee chair meeting logs, looking for escalations. We're still at the early stages of introducing the AAA reporting, so it's very format here. But can we just go through digital data first of all? How's that?
No, there are no alerts.
Okay, any issues anybody wants to raise with Hassan at this point? Quality committee, Anna? Okay, thank you. Just looking through, we come to next. We've had a couple of quality committees. People committee?
We covered just, this goes back to the November committee, we've had a committee just last week, but one of the key alerts was the audio safe working issues, which we feel
Good, okay. Any questions, Mr. Burney? Finance and performance bill?
No investigations in there, just the immediate time plan, still in progress, that was an extra
Yeah, we've got plenty of time to focus on that. We've got plenty of time. We will be focusing on it. So we've got 2 finance and performance reports. Audit, David's not here, but she's certainly spent nothing to escalate. And I think that's it on the committee chairs. Then we're into the learning from disability exception, Rachel.
Nothing to escalate, please recognise the point.
Anybody want to flag up anything that's been properly chewed over? Then there's the action log. We've got a few more items here, but nothing of enormous concern. We're still working on the response to the CBD. County Durham and Durham Foundation Trust review. We'll be looking at the quality committee and also then at all later on. So that's well in hand. Patrick.
So, Chair, just on that specific action we brought, just to update forward, colleagues out there, enrolled children as by the ICB to provide a separate assurance of achieving that into the ordinary report as well. Which,
yes, wasn't that nice? 19 areas, each one with 5 subheadings, and that was a light touch in ICB. Yeah. Okay, second item, we're due to get an update on the National Centre for Neurotechnology and Neuro Restoration. To make a note, so we'll get a copy of it in due course. All the others are green, so unless anybody wants to raise any, we're done on the action log. We are on 3 minutes over, 2 minutes over. So I think, first of all, thank you colleagues, thanks for observers for your engagement with this. We have private board, and I think I can keep to the fixed, the existing starting time to that, which is at 12.